Yes, esophageal cancer is one of the few cancers that is increasing in incidence in the Western world, while most other cancers are decreasing. The reasons for this are not entirely clear, but it is related very strongly to the epidemic of gastroesophageal reflux disease that we see in the Western world. And the type of cancer that's increasing is the type that's related to reflux disease. Barrett's esophagus is a precancerous condition in the esophagus which develops primarily as a result of chronic acid exposure of the lining of the esophagus. So the esophageal lining is exposed over months or years to acid, and this causes a transformation in the lining of the esophagus into an abnormal lining that is not normally present there. And this abnormal lining is prone in some patients to becoming a cancerous growth. There are no typical symptoms of Barrett's esophagus, and so that is one of the real problems with this entity. We're not able to identify patients with reflux disease who have Barrett's based on their symptoms. Barrett's is diagnosed by endoscopy. So endoscopy is a technique where we pass a flexible instrument down into the esophagus. We're able to look at the lining of the esophagus. And there are two aspects to the diagnosis of Barrett's. One, the visual impression that there is a altered lining inside the esophagus, and then biopsy confirmation of that by taking targeted biopsies from the area. We know that 15% of the US population has reflux disease on a fairly regular basis, and 10% of them will develop Barrett's esophagus. So it's a sizable proportion of the population. So patients with Barrett's esophagus are at the complicated end of the spectrum of reflux disease. You know, reflux disease varies from a mild situation where you have heartburn occasionally or a couple of times a week to having precancerous and cancerous changes as a complication. So Barrett's is somewhere up there on the curve of complications, and it is a warning sign to us that enough reflux has taken place over a period of time to cause this transformation in the lining of the esophagus. So the example that I give patients with Barrett's esophagus is that we are not able to get tissue to look at under the microscope to see if there are changes of dysplasia taking place. So this is very similar to getting a pap smear, where to get at the tissue you have to have an examination and a device has to be passed in. So every 2 to 3 years we recommend endoscopy with biopsy from the area of abnormal epithelium to see if there's a change in the lining heading towards cancer, a change that is called dysplasia. Well, Barrett's is itself a pre-cancerous condition, and so it by itself is a situation where you have an increased risk of cancer if you have Barrett's esophagus. But only a small proportion of people with Barrett's esophagus go on to develop cancer. And we don't understand completely the cellular mechanisms, but in a simple way, what we can say is that precancerous cells have a tendency to accumulate genetic defects, and these genetic defects, when they accumulate to a certain point, that is in fact what constitutes cancer when there's uncontrolled growth of the cell. So in Barrett's esophagus, we think that acid is one of the inciting factors that leads to this cellular disturbance that promotes the development of dysplasia and then ultimately cancer. Yes, we are seeing a change in the epidemiology of both Barrett's and esophageal cancer. So Barrett's esophagus is predominantly seen in white Caucasian populations. There's a predominance in men, but we are beginning to see a rise in the incidence of Barrett's esophagus and esophageal cancer in women as well, although the rates in women tend to be a lot lower than in men. Recently, there have been descriptions of Barrett's esophagus incidence rising in both Hispanic Americans and also in African Americans, although the rates in those populations are lower than they are in white Caucasians. It's a very small proportion of them. The rough estimates are about 4 or 5 in 1,000 patients per year will develop esophageal cancer. So each year in a population of 1,000 patients with Barrett's, 4 or 5 will develop an esophageal cancer. However, the problem that we face currently is that we have no method of identifying who the patient is who's going to get an esophageal cancer and at what stage. Barrett's esophagus is the primary risk factor, but other factors can play a role. We've increasingly become concerned about obesity, particularly obesity in the central part of the abdomen, so that means abdominal obesity. And obesity is also an independent risk factor which adds to the risk created by Barrett's esophagus. And this is one explanation offered for perhaps why we are seeing a higher incidence of esophageal adenocarcinoma, that we have a growing incidence of obesity, and that could be playing a role. Medical treatment for Barrett's esophagus, which means acid inhibitory drugs, lifestyle changes, dietary modifications, etc. We also have methods now to treat the Barrett's esophagus itself. So we have a device called a radiofrequency ablator, or the HALO device, which can ablate the Barrett's epithelium or destroy the abnormal epithelium, and then the normal tissues return or are restored, and the patient can be rendered Barrett's free. For esophageal cancer, the treatment is almost entirely dependent on the stage of the disease. For very early stage disease, as in the case we have discussed here, the treatment can be endoscopic. The cancer is localized to the surface lining of the esophagus. It's detected at a very early stage. There's no spread, and we can take it out through the endoscope using specialized devices. So the HALO device is a revolutionary device in the management of Barrett's esophagus. It uses radio frequency to provide a controlled injury to the abnormal cells. Contrary to popular belief, high energy devices are really quite unsafe in the esophagus. So people often ask us about, can you use a laser and laser it away? The problem with lasers is that they cause a very deep injury to the esophagus, and the esophagus is a relatively thin wall. And what we are looking for is a device that provides a very controlled injury to the surface area, surface of the esophagus, because that's where the cancer is located. And that's what radiofrequency does. And the HALO device is a radiofrequency ablator. It really depends to a substantial degree on the extent of the Barrett's esophagus there is. So in patients who have a very limited area of Barrett's esophagus, the treatment may be very short in duration. And if you have very extensive Barrett's esophagus, we may need to apply multiple treatments in the session. But on average, it's somewhere between half an hour and 45 minutes. It can simply be divided into a very localized cancer in what we call the mucosa or an intramucosal cancer, and that's treated by endoscopic means where we remove it. Then we have deeper involvement of the wall of the esophagus, but without evidence of spread outside the esophagus and without evidence of distant metastases anywhere else. And that type of cancer is typically treated by a surgical resection of the esophagus. And then there's the third group of people who have deep invasion of the wall of the esophagus, and there the treatment might be surgical or might be a combination of chemotherapy, radiation, and surgery, or variations thereof. And the last one is where it's basically through the wall and a spread elsewhere, where any kind of surgical or curative therapy is not possible, and there we give chemotherapy and radiation for palliation purposes. It is highly variable. So there are patients described who within months of having no dysplasia progress to high-grade dysplasia and have an early cancer, and we actually saw that in this gentleman that was described. First examination, when we found that he had high-grade dysplasia and an early cancer, we knew that at an examination 2 years earlier, he had none of those changes. So he progressed all the way to cancer within the space of 2 years. And there are shorter progressions described as well. However, it's also noteworthy that he had been stable for approximately 10 years before he got the change. So it can happen at any time, and then it can progress quickly. If you have chronic reflux disease, and by that we mean if you have symptoms of heartburn or regurgitation more than 2 times a week, where it's interfering with your ability to eat, sleep, or function in some way, then you very likely have reflux disease. I think the first thing that I would say is that one needs to treat reflux disease with some degree of respect, in the sense that you do need to alter your lifestyle, modify some of your habits, perhaps change your eating habits, perhaps change when you eat dinner and when you go to bed. And then I would also consider seeking medical attention for your symptoms with medical therapy. Now, once you've had reflux disease for a prolonged period of time, and most people would agree that if you've had reflux for between 5 and 10 years, that's the time you want to start thinking about getting evaluated to see whether you have Barrett's esophagus. You need to take it seriously and be religious and meticulous about medication, lifestyle changes, and participating in the program where you go for regular checkups with endoscopy and biopsy to look for changes of dysplasia. Yes, I think the halo, the case that we've illustrated today, if I had had this gentleman 10 years ago, he would have been facing complete removal of his esophagus. And this is in fact what we have done 10-15 years ago. So there are remarkable new changes that have taken place that offer people, even with early cancers, a very simple endoscopic treatment which works in an hour and you just go home that day.